First of all, I'd like to thank the organizing for inviting me. This is the first meeting after TCT for me. I was spending two years and a half for COVID, and then first meeting of the last week in TCT, and this is the second meeting for me. I was concerned to have, after two eminent speakers speak about this, the left main. Actually, you have two debates in coronary intervention, one PCI left main, PCI CABG, PCI in multi-vessel, PCI versus CABG. I'm concerning with the left main. This is the left main. What's important? Because distal location more than 70%, its calcification more than 50%, and with multi-vessel disease in 70%. Actually, we have a prognostic factors and technical considerations, whether emergency, as Dr. Tariq Helbi said, elective high risk versus low risk, as Dr. Ahmed said, and then the technical consideration, we're speaking about isolated left main, other vessels, aortoosteal, shaft locations, bifurcation, use of support devices, debulking devices for preparation, and optimization using IVAS or OCT. Then the different techniques for the left main. If we illustrate the revascularization left main with the contemporary evidence, the main compare for 3 years follow-up, and this is 2000, and this is long-term, actually there's no significant difference in this. The only problem is TVR. The TVR is in favor of CABG. Then they have a lot of trials starting from 2007, as you can see, the most important layman's that myocardial infarction, no difference stroke, but CABG is better. Then starting the Centex. I think the Centex, it started to us to give us the courage to go with the left main. CABG is better for revasc, but for stroke, PCI is better. The surgeon didn't mention evident in any stroke. There is no difference in myocardial infarction. About all these trials, in these large series of comparative, mainly non-randomized studies, including midterm 3 years, follow-up, these are compared with CABG for the treatment of unprotected left main associated with similar instance of hard clinical endpoint, death MI, and decreased instance of stroke with increased need for repeat TLR. Then starting the important trials, which are Nobel, Centex, Excel, Precompats, but as we can see, if we accumulate these 5 randomized trials, 4,600 patients, the mean follow-up 5.6 years, including Excel, Nobel, and Centex. As you can see, there is no significant difference in all-cause death. In even the cardiac death, there is no difference. If you compare for the long-term mortality for 4,000 patients with Centex 5 years, Precompat 5 years, Excel 5 years, and Nobel 5 years, no difference in death. If you compare the stroke with 30-day strokes for all these trials in favor of PCI, actually if you 1 year stroke also in favor of PCI, including with a median of 39 months. Actually for the 5 randomized trial, 4,000 patients with the mean 5.6 point, if a high 5-year heterogeneity, if exclude Nobel trial is removed, this is in favor of PCI versus CABG. But the important questions which raised after Excel about the procedural or non-procedural MI. For the procedural MI in favor of PCI, but non-procedural MI in favor of CABG. This is speculating what the difference between this. I think the behind the sign, the Excel controversies, the first controversy is mortality is greater after PCI compared with CABG in left main disease, and if so, doesn't this trump all? The second controversy, why was the specific protocol definition of MI selected rather than the universal definition? So if you compare the all-cause mortality, actually there's no difference of the individual patient analysis of 11 randomized trials with the left main, there's no difference in death. If you compare with diabetes or no diabetes, actually it's more for diabetes in favor of CABG, with a high Centex score also in favor of CABG. If they compare the left main mortality here, 4,000, yes, fixed dose in favor of CABG here, there's no difference in all of this. The most important trial, which is started to have the carriage to left main in the Centex, which long-term is 10 years, no difference. What's the 2 important last trials, Excel and Nobel? We look to this slide, it's 1,900 for Excel patients. Nobel is 1,200. The number of centers, 126 versus 36. Number of countries, Excel is more, 17 versus 7. And Centex score inclusion less than 32 for Excel, no restriction for Nobel. The primary endpoints, death, MI, stroke, but in Nobel, adding revascularization. including peri-procedure MI, yes for Excel, no for Nobel. For stent, is it designed, and the other is biometrics. 3-year definite stent thrombose is 0.8 versus 3% in Nobel. A definite stent thrombose led the symptomatic grafts is yes for Excel, but no Nobel. Actually, which is astonishing, the stroke for PCI CABG is more with the PCI in Nobel, which is astonishing, less with PCI, and worse PCI prognosis with higher syntax, yes for Excel, when no with Nobel. Then we come to an important part, actually after Dr. Tariq Helmi and Dr. Ahmed, about the lesion complexity and location. We're speaking about the bifurcation angle, the difference in vessel size, the mismatch, single versus double stents, which double stent technique, maximal stent diameter, and the need for IVUS. What the different stent strategy, stenting crossover, kissing stents, and T-stentings. If you look at these slides, if you have a small left main versus big left main, if you have a small left main with LCX, actually crush or T. If a big left main with LCX, you use kissing. If you have a small left main without CX and big left main without CX, the best is across LCX. I think that all of us doing left main, but the most crucial point is the LCX. Is one of the key elements for indication left main. Because if you don't have a small, if a small LCX, you go direct for the left main LED. But depending on the size of the CX, the area of jeopardized myocardium, the ostial location of atheroma plaque, a difference of the atheroma and bifurcation angle. If you can look to this slide from the Euro PCR, the size of the CX, if it's excluded, ignore it. If it's small, less than 2.5, do a protection wire. If it's large CX, you have plaque distribution, lock it, calcium extension, bifurcation angle, the diameter of LED and CX, and so go protection wire, provisional stenting, or two-stent technique according to the criteria of Dr. Ahmed said. LCX, look, it's not diseased, and look for the angle. Diseased with atheroma and the angle. If it is not diseased, the LCX with the angle more than 60, only protection wire. If less than 60, protection wire with or without ballooning and then with the kissing after stenting left main LED. If it is diseased, look for the calcium and diffuse atheroma. No, the protection wire, and finally with kissing. If yes, it's the time now for stent technique. Look for the angle. If the angle is less than 60, you have kilot and crush. If more than 60, you have T technique and kissing stents. So the main site of restenosis, the left main, is the restenosis LCX. And this is the problem of strategy. If you use restenosis, left main DCX, CABG, isolated restenosis, we have well, nowadays medical treatments. If you can do ballooning, the DCP. If it's a large CX, you cannot do this. Sometimes they consider CABG. I'm not going into cases for the left main because of time, for the left main LED, but I'm speaking about the heart team. The heart team is essential left main. Don't do ad hoc except in emergency. I disagree with Dr. Tari about the STEMI, and we don't do STEMI with the Impella in our country. We do it a lot of STEMI, direct. We don't have time for Impella. We don't have Impella. We don't have time for intra-aortic. 4 o'clock in the morning, just put the wire, just open the LED, and no need for heart team. But for elective cases, yes, heart team, clinical cardiologists, intervention, and cardiac surgeons, and expanded heart team. This is all you must have for expanded heart team. So what are the last guidelines? This is the European guidelines, 2018. For the, I'm looking only for the left main. I'm said that this is only the debates between 3 vessels and then the left main. Left main, if you have a syntax score less than 22, PCI and CABG equal. It's class 1A. If a syntax score is 23 to 32, CABG class 1A, but PCI is 2AA. And if the syntax score is more than 32, yes, PCI class 3B is contraindicated, except in some situations if you have a high Euro score, CABG class 1A. Not in all patients is contraindicated, but sometimes you have incomplete revascular patients, but in a sense, it should do CABG in such patients. So what about highlights of the PCI procedures? IVUS is strongly recommended to guide left main PCI. FFR strongly recommended assess borderline lesions. Lesion preparation is essential. Usually, direct stenting strongly discouraged. Distal left main provisional stenting recommended. Hemodynamic support sometimes permitted, but not usually required. Vascular access and closure, according operator with a radial or femoral. Staging liberal use permitted, 2 weeks preferred. Routine follow-up and geography is not permitted. For the CABG highlights on pump or versus on pump, arrested hearts, this supporting the operation and the experience. Ascending aorta assessment is important. Intraoperative EE, arterial graft are prepared conduit. So it's appropriate to start unprotected left main in patients who are good candidate for surgery. Yes, it is, because there are two different procedures, as you can see. So why not PCI for all? Because sometimes your inability to take depth, diffuse disease or unpredictable major branches, absent access, inability to completely revascularize, patient preference, and some CKD. 24 hours post-CABG and this 24-hour post-left main. So the patient information consent is very important. Recommendation left main. Encourage heart team. Rule both PCI and CABG depending on clinical scenarios. Heart team approach is important. Stenting ostial left main, good results. This is only our job, the cardiologist. Left main bifurcation continue to pose considerable challenges. Intracoronary imaging is important, IVAS OCT. Imaging guidance optimize the results of the patients. So left main stenting, excellent option, so many patients, but only if meticulous techniques are applied. Finally, thanks to Syntax, left main PCI is not taboo, entered into European guidelines with a class 1 indications, and celiac disease is the limiting factor, PCI, not the left main or location itself. Location left main, lesion, distal or non-distal, and the technique used is no longer relevant nowadays. Contemporary trials challenge surgery as the default strategy, but in isolated disease, the only barrier is improper technique. And thank you very much.
Thank you.